When a clinician looks at a raw lab report, they are often confronted by a chaotic matrix of numbers, reference ranges, and isolated red flags. The instinct to memorize these values line by line is a tactical error. Without context, these isolated data points remain noise rather than information. Interpretation begins by understanding the predictable cellular logic that dictates how and why these biomarkers enter the serum. This diagram establishes the analytical workflow. We identify the source organ, determine the specific marker it releases, map that marker into a clinical pattern, and conclude with a specific diagnosis. Adopting this modular approach enables a clinician to synthesize raw data into a precise diagnostic framework. The liver functions as a dual-system organ, managing both internal cellular metabolism and an external biliary drainage system. Cytosolic enzymes, specifically AST and ALT, are normally contained within hepatocytes. They leak into the bloodstream when the cell membrane is compromised by necrosis or inflammation. A proportional elevation of AST and ALT signifies a hepatocellular injury pattern, common in viral hepatitis. The biliary system follows a different rule. Membrane-bound enzymes, ALP and GGT, are concentrated in the bile ducts. Their serum levels rise when physical obstruction triggers increased synthesis. This elevation identifies a cholestatic pattern, indicating a biliary blockage. Distinguishing these two patterns narrows the clinical focus. AST and ALT indicate cellular damage, while ALP and GGT indicate a structural plumbing issue. Renal diagnostics focus on the kidney's mechanical capacity to clear metabolic waste from the circulation. This filtration efficiency is monitored primarily through two markers: blood urea nitrogen, or BUN, and creatinine. This cross-section shows the glomerulus, the primary filter. Creatinine is a constant byproduct of muscle breakdown. Because production is steady, serum levels depend entirely on clearance. As glomerular filtration rate drops, serum creatinine and BUN levels rise in direct proportion. An isolated, consistent elevation in serum creatinine confirms a measurable decline in the kidney's filtration capacity. Endocrine diagnostics rely on the logic of negative feedback loops to maintain systemic hormone levels. The pituitary gland acts as a sensor, producing TSH to stimulate the thyroid gland to make T3 and T4. In primary hypothyroidism, T3 and T4 drop, causing the pituitary to increase TSH production. Conversely, an overactive thyroid producing excess T3 and T4 suppresses TSH. TSH levels move in strict inverse proportion to thyroid hormones, making the pituitary's response the most sensitive metric for diagnosing thyroid dysfunction. While organ failure is often acute, the lipid profile allows for the assessment of long-term metabolic risk and atherosclerosis. Low-density lipoprotein, or LDL, acts as the primary vehicle for transporting cholesterol into the walls of peripheral arteries. This cross-section illustrates the accumulation of plaque. Markers like apolipoprotein B and lipoprotein A offer a more precise count of the specific particles that drive this atherosclerotic process. These atherogenic markers are balanced by high-density lipoprotein, or HDL, which facilitates cholesterol transport, moving excess lipids back to the liver for excretion. Assessing cardiovascular risk requires weighing the balance between this lipid deposition and the body's capacity for clearance. In critical emergency diagnostics, clinicians must prioritize the rapid identification of acute, irreversible cell death, a process clinically known as infarction. This process is best illustrated by cardiac infarction. When heart tissue dies, it releases troponin, a structural protein found exclusively in cardiac muscle, into the circulation. The detection of cardiac troponin in the serum provides definitive evidence that myocardial cells have been destroyed. Similarly, while older protocols utilized amylase, lipase has become the more specific marker for identifying acute pancreatic inflammation and damage. In acute scenarios, markers like troponin and lipase provide high specificity, cutting through clinical ambiguity to confirm organ-specific damage. Systemic survival depends on the narrow regulation of blood pH, which must remain between 7.35 and 7.45. Interpretation of an arterial blood gas panel starts with the pH. We first determine if the patient is in a state of acidosis or alkalosis. To find the disturbance source, we use the Rome rule. Under respiratory opposite, if pH drops while carbon dioxide rises, the failure is respiratory. Under metabolic equal, if pH and bicarbonate both drop, the kidneys or metabolic pathways are responsible. The Rome rule provides an algorithmic path to identifying the root cause of a metabolic crash. Every organ system operates within a logical, integrated biochemical framework. Enzyme leakage characterizes liver damage, filtration waste defines the kidneys, and feedback loops govern the thyroid. In acute settings, the release of specific structural proteins confirms irreversible damage to the heart and pancreas. Recognizing these consistent functional patterns is the key to accurately decoding any complex systemic pathology. Trust the physiological pattern, not the isolated number.